400 million people around the world have type 2 diabetes. In the United States, 14% of adults, which corresponds to about 1 in 7 adults, have this disease. Type 2 diabetes is a very serious chronic condition that is often the gateway to other serious health complications, increased medical costs, and sometimes even death. A lot of cases of type 2 diabetes are actually caused by behavioral factors, which means that type 2 diabetes is preventable through interventions such as healthier dieting and increased physical activity, which is why we have been working this summer in a prevention effort to promote earlier and more efficient screenings for type 2 diabetes. This work is done in partnership with Alliance Chicago, a national network of over 40 federally qualified community health centers around the country. These are the health clinics that are serving the least resourced members of their communities. So consider a patient who walks into one of Alliance's clinics. Say this patient is 23 years old, is obese, has a family history of type 2 diabetes, and is also hypertensive. In reality, this person is at pretty high risk of developing type 2 diabetes. And so what can the provider do for them to identify their risk in this visit? The current screening guidelines for type 2 diabetes are mandated by the US Preventative Service Task Force. And these guidelines serve also as reimbursement guidelines for health clinics, so when they can get reimbursed for a screening or not. And these guidelines are a simple checklist of two things: whether or not a person is between the age of 40 and 70, and whether or not their BMI is greater than or equal to 25. So consider this patient again. Sure, their BMI meets these cutoffs, but their age doesn't. And so unless the health clinic has the capacity to absorb the cost of this screening, this clinician will likely not screen this patient for type 2 diabetes, and their risk will just persist. And so you may be wondering, how often does this actually happen? And this is where Alliance came to us this summer. They noticed that in their patient population, among people already diagnosed with type 2 diabetes, about half of them would not have met these screening guidelines. And so this person I described earlier would have fallen out of these guidelines and been a part of that 50%. And what's worse is that this 50% not caught by the federal screening guidelines disproportionately come from racial and ethnic minority backgrounds. And so our goal this summer was to transcend the federal screening guidelines and give providers a more personalized tool to screen their patients by building a predictive model for a person's risk of developing type 2 diabetes in the next 3 years. Alliance provided us with a wealth of information in their de-identified electronic health records. We received data on over 1 million patients from 24 health centers around the country, and this amounted to about 8 million visits, dating all the way back from 2006 up until the current year. And in addition to all of these medical history values, we decided to supplement the data with information from the American Community Survey, because we strongly believe that place and social factors matter in determining a person's health outcomes. So let's go back to the federal screening guidelines and use that as a baseline in our patient population. The federal screening guidelines would recommend, among our patients, screenings in 20% of the visits, and at that screening rate, it would only accurately detect 53% of true cases of people who would go on to develop type 2 diabetes within the following 3 years. The model we built this summer shows a 10 percentage point increase at this same screening rate. And what's also great about the model that we built is that we can actually vary the amount of screenings we perform. So we can actually get the same coverage as the screening guidelines by screening less patients. Or even better, if we screen just 5% of visits more, we can truly pick up 74% of the cases in which people will go on to develop type 2 diabetes. And when you consider that the number of visits that happen every year is on the magnitude of hundreds of thousands, this has a very significant impact. So let's consider again that patient I described at the beginning, who would have been missed by the federal screening guidelines. Using the model we built, we can now provide a risk score for that person's risk of developing type 2 diabetes. And where is this model headed? Directly into the hands of clinicians and health providers to perform personalized screenings for their patients, connect the patients who are at highest risk of developing diabetes to the interventions and services to lower their risk, and ultimately to prevent more people from being diagnosed with type 2 diabetes and keep the Alliance Chicago population healthier and living longer. Thank you.